great field. And now we get the last lecture on which actually mingle quite a bit with this presentation about Sean Pinney, who is the chair of Mount Sinai Morningside and uh, now the system director of heart failure. Everybody stays. We actually have a draw. Want somebody to go home with the, I think it's a iPad. Good. So now we talk about medical management of diastolic dysfunction. We all talk about systolic, now the diastolic dysfunction. Does the emperor finally have clothes? Title has been selected by Dr. Jagat Narula. Okay, Sean, always your great teaching. Right
Thank
here.
you.
Thank you.
Thank you, Dr. Sharma. My thanks to you and Dr. Kinney and Dr. Narula for the great honor of being here this afternoon, although I have to say I'm a little unnerved because now I'm not sure if people are staying because they want to hear me or they want the iPad. So these are my disclosures. So what I'd like to do is take about the next half hour or so and review three things. Talk a little bit about the pathophysiology of heart failure with preserved ejection fraction. Spend the majority of the time going over medical therapy for HFpEF, drawing upon the recent expert consensus decision pathway that was just published in JACC, and then wrap up by setting the stage and discussing some of the emerging device-based therapies that are currently undergoing clinical trials. So what is HFpEF? Well, HFpEF is heart failure. And what that means is that patients have signs and symptoms of congestion, breathlessness, exercise limitation that's caused by a structural or functional abnormality in the heart. In this case, it's not systolic dysfunction. Rather, it is an inability of the heart to fill and to eject blood at normal filling pressures. Now, this has to be corroborated by some objective evidence. You either have to have elevated levels of natriuretic peptides, or there has to be objective evidence of either peripheral or pulmonary congestion. And this could be by physical exam, or by radiology, or by invasive hemodynamics. And if you put those things together, you have a diagnosis of heart failure. In order for it to be HFpEF, there has to be two other things. Number one is there has to be an ejection fraction that is greater than or equal to 50%. And this aligns with the recent redefinition of heart failure that was published a couple years ago. And there has to be the exclusion of other mimickers of HFpEF, things like infiltrative cardiomyopathy, an example of which would be cardiac amyloidosis, hypertrophic cardiomyopathy, pericardial disease, valvular heart disease. I'll also throw in there pulmonary arterial hypertension, and then lastly, high output heart failure. So we know that there are a variety of pathophysiological mechanisms that produce the syndrome of HFpEF, and not every patient is going to have all of the heterogeneous pathways at play at any one point in time. But one thing that is shared is a common physiology, which is that there is diastolic dysfunction. There is stiffening of the left ventricle that leads to an elevation in ventricular filling pressures, atrial filling pressures, either at rest or with exercise. Now, for example, we've recently learned that truncating titin mutations, one of the manifestations of that can be a form of myocardial fibrosis that can lead to the syndrome of HFpEF. We also know that inflammation, and I'll talk about that in a minute, can also lead to myocardial fibrosis, leading to myocardial stiffening and the symptoms of HFpEF. But it goes beyond that. We know that there can be chronotropic incompetence, atrial fibrillation, which Dr. Ducapati just talked about, significant arterial remodeling, both in terms of the peripheral vasculature as well as the pulmonary vasculature, leading to arterial stiffening and endothelial dysfunction. And of course, renal dysfunction, which is a big driver for salt and water retention and the symptoms of congestion. But what we're really learning is one of the main drivers of HFpEF is inflammation. And we have learned that the cardiometabolic syndrome, obesity, type 2 diabetes, hypertension is a pro-inflammatory state, and that there is a release of a number of inflammatory and pro-fibrotic cytokines like interleukin-1, interleukin-6, TGF-beta, all of which go to cause downstream effects, not only endothelial injury and endothelial activation, but end organ dysfunction. So at the level of the kidney, there can be tubular injury leading to sodium retention. In the peripheral vasculature and the peripheral muscles, we know that there is sarcopenia as a result of chronic inflammation. We'll talk a little bit more about the mechanisms inside the heart, but in the lungs, there is pulmonary arterial remodeling that can lead to adverse hemodynamic load onto the right ventricle. And we know it also affects the bone marrow with suppression of red cell genesis and the development of anemia. Let's focus a little bit more on that low level of chronic inflammation. What this does is it causes the endothelium in response to IL-6 and IL-1 to upregulate adhesion molecules. This then attracts leukocytes to the endothelium that then are stimulated to produce myofibroblasts, and those myofibroblasts produce collagen, and it's that collagen that leads to the stiffening of the left ventricle. The chronic inflammation does more than that. It also increases the number of reactive oxygen species. And as a result of that, this becomes a nitric oxide deficient state. And in the absence of an adequate amount of nitric oxide, we see a decrease in soluble guanylate cyclase, a reduction in cyclic GMP, and a reduction in phosphokinase G. This then leads to a number of consequences. There's passive stiffening and tension in the myocardium, and there's also a pro-growth stimulation for myocardial hypertrophy, all of which leads to stiffening in the left ventricle. So it's not surprising that we saw a recent hypothesis tested and the results presented at the ESC meetings just a couple months ago, testing the hypothesis that if we treat cardiometabolic syndrome and obesity with a GLP-1 agonist like semaglutide, perhaps we can have a beneficial effect in patients who have established heart failure with preserved ejection fraction. And in fact, we're beginning to see that that signal is true. We saw in this particular trial a reduction in body mass, a reduction in body mass index, and improvements in functional capacity as measured by KCCQ and 6-minute walk. Now, the trial was not powered to detect hard clinical endpoints like heart failure hospitalizations or mortality, but when you aggregate the number of serious adverse events that occurred in the 500 or 600 patients that were enrolled in this trial, we can see that it was less frequent in those that were treated with semaglutide. So much, much more to come on that. Well, how does this pathophysiologic mechanism progress over time? Well, initially, as I alluded to, we recognize that there's LV stiffening that leads to an increase in left ventricular pressure and an increase in left atrial pressure, either at rest or with exercise. And as this progresses over time, we begin to see further increases in left atrial pressure, decreases in left atrial compliance, significant left atrial remodeling, which in some cases can lead to atrial functional mitral regurgitation, something that we've recognized now just over the last couple of years. And of course, intermittent or paroxysmal atrial fibrillation. As this syndrome continues to progress, what we're ultimately left with is problems on the right side of the heart. That increase in left atrial pressure leads to chronic elevations in pulmonary arterial pressure. That increased load on the right ventricle causes right ventricular enlargement, right atrial enlargement, and functional tricuspid regurgitation until what you're left with is a patient who is symptomatic with almost minimal exercise. So how do we treat it? Well, years ago, and it wasn't that long ago, all we had were loop diuretics, prescribed loop diuretics to try to relieve some of the symptoms of congestion. But now, one of the greatest miracles that have happened in cardiovascular care was the discovery of SGLT2 inhibitors and their use in patients with various forms of heart failure. So why do SGLT2 inhibitors work in heart failure and why do they work in HFpEF? And the truth is, we don't know. And I tell you that when I meet with my patients and I say, I want you to take this drug, I don't know why it works, but it works. It is the one thing that convinces them to take the drug, and they say, well, at least you're honest. So I don't know why it works, but there's some very, very interesting hypotheses which I do think are true and they are at play. So the first one is that the SGLT2 inhibitors have a beneficial effect at the level of the tubule in the kidney. They interfere with sodium hydrogen exchange. They block that salt and water retention. That then leads to less cardiomyocyte injury, less sodium avidity, and improvement in the clinical syndrome. And I think it's one of the mechanisms that leads to the early improvement that people see when they start these medications. I think there are two other mechanisms that are a little bit more compelling and a little bit more interesting. So I want you to think about the epicardial fat. So epicardial fat, particularly in obese patients, is abundant. But it's not just present, it is very biologically active, and it releases a number of those pro-inflammatory, pro-fibrotic cytokines. The SGLT2 inhibitors actually induce changes that decrease the amount of epicardial fat and decrease myocardial mass. And so this was work that was done here at Mount Sinai by Dr. Juan Bataman and also Carlos Santos Gallego, first in an animal model, showing in MRI images that the treatment of the animal with an SGLT2 inhibitor could decrease the amount of epicardial fat. Following that, in patients with heart failure and reduced ejection fraction, a randomized trial, the use of empagliflozin showing that there was significant reductions in left ventricular hypertrophy as measured by MRI and improvements in functional capacity. Now, a second or third mechanism that might explain the beneficial effects of SGLT2 inhibitors is one that's being put forward by Dr. Milton Packer, and he's written extensively on this subject in the last 2 years, bringing to our attention this concept of nutrient deprivation signaling, which is actually a good thing. And it's a good thing because it induces sirtuin-1, and sirtuin-1 tends to antagonize a number of adverse pathophysiologic processes. It tends to have a number of effects at the level of the myocardium. It has beneficial effects at the level of the tubule. It also affects the mitochondria, and it promotes mitochondrial health. SGLT2 inhibitors induce SIRT1, and as a result of that, help to activate this nutrient deprivation signaling pathway to the benefit of patients. Okay, where's the data, where the evidence, the clinical evidence to support the use of SGLT2 inhibitors? Well, it starts with Emperor Preserved. This was a phase 3 randomized, double-blind, placebo-controlled, event-driven trial in patients with and without type 2 diabetes and who had clinical heart failure, symptomatic, with an ejection fraction greater than 40%. Now, I told you before that you have to have an ejection fraction greater than 50%, but this aligned with previous definitions of HFpEF. And those patients were randomized to treatment with empagliflozin 10 milligrams once daily or a placebo, and the composite primary endpoint was heart failure, hospitalization, or cardiovascular death. So this was a little bit smaller trial compared to the ones that Dr. Moran shared with you with 15 and 16,000 patients, but in the heart failure world, 6,000 patients is a big trial. And what this showed was that there was a 21% relative risk reduction in that composite endpoint of heart failure, hospitalization, or cardiovascular death in those patients treated with empagliflozin. There were also significant improvements in quality of life as measured by the Kansas City Cardiomyopathy Questionnaire. However, and this is a theme that you're going to hear a couple more times, when we drill down a little bit more and we look at that composite endpoint, it was really driven by reductions in heart failure hospitalization. And unfortunately, empagliflozin did not have any effect in reducing cardiovascular death. Empagliflozin is not the only SGLT2 inhibitor out there, so for balance, we should talk about dapagliflozin and the DELIVER trial. Very similar setup, published almost contemporaneously with Emperor Preserved. Again, 6,000 person trial, had to have heart failure and ejection fraction of at least 40%. This also showed a similar reduction, 18% relative risk reduction in the primary composite endpoint of worsening heart failure and cardiovascular death. And once again, the outcome was driven primarily by the reduction in worsening heart failure. And it was important when they looked at the range of patients, the range of ejection fraction of patients enrolled in this trial was that there seemed to be no attenuation of benefit, meaning that patients at the highest range and the lowest range of ejection fraction showed benefit. Now, I have to talk about one other trial and one other compound, and that is the SOLOIST worsening heart failure trial, which was conducted by my colleague, Dr. Bhatt, and this tested sotagliflozin. So this is important for two reasons. Number one is that this was a trial of the introduction of SGLT2 inhibition in the acute setting, patients were either hospitalized or recently discharged from a heart failure hospitalization, at which time they were randomized to either sotagliflozin or placebo. It's also important to say that the reason why this was an important trial in the acute setting is because there would be potential concerns about starting one of these medicines in the context of treating someone with decompensated heart failure. Is it going to lead to acute kidney injury? Is it going to cause hypotension? So something that needed to be tested for safety. The other reason this is an important trial is that sotagliflozin, unlike IMPA and dapagliflozin, is a combined SGLT1 and 2 inhibitor. It blocks the SGLT1 receptor in the intestine, which then blocks those spikes in glucose and evens out glucose absorption over the day. So what Dr. Bhatt and his colleagues found was that in these almost 1,200 patients that were randomized with diabetes after a recent hospitalization, that sotagliflozin significantly decreased the rate of heart failure hospitalization and cardiovascular death. The trial, unfortunately, was stopped early, not because of anything Dr. Bhatt did, but because the sponsor withdrew some of the funding. It's important to note that it was safe. There was no signal of increased risk of hypotension or acute kidney injury as a result of that. And if we look at the forest plots and we look at the subgroups and we focus in on those who had an ejection fraction greater than or equal to 50%, because I failed to tell you that it was a trial for all patients with heart failure, and about 20% had HFpEF. You can see that the point estimate is to the left of 1, suggesting that sotagliflozin is beneficial in patients with heart failure and preserved ejection fraction. So we can now see that across a variety of ejection fractions, these SGLT2 inhibitors have beneficial effects, reducing cardiovascular death, heart failure hospitalization, again, primarily being driven by heart failure hospitalization, and also decreasing the total number of the first and recurrent episodes of heart failure hospitalization. But there was this signal, which is that does this hold for patients who have higher ejection fractions? In the DELIVER trial, we didn't see it, but in the Emperor Preserve trial, there was this signal that for those individuals enrolled in Emperor Preserved, that those who had an ejection fraction greater than or equal to 65%, that there was no benefit, that the hazard ratio was right around 1. Now, I'll draw your attention to the hazard ratios around those point estimates. You can see they're quite wide because there weren't as many persons enrolled in the trial who had such a high ejection fraction. Well, how do you level this out? And Dr. Muthu Viduganathan published a really nice meta-analysis in The Lancet trying to harmonize all of the SGLT2 inhibitor trials in patients with heart failure, specifically looking at those with various levels, various ranges of ejection fraction. And what he found was that when you harmonize these trials, there was a consistent signal of benefit regardless of ejection fraction, including those individuals who had an ejection fraction greater than or equal to 60%. Again, the point estimate is to the left of 1, suggesting that there is benefit in those patients even with higher ejection fractions. Moving on, we now have from the expert consensus decision pathway recommendations for additional therapies. The level 1 recommendation continues to remain treatment with a loop diuretic, and I won't go into great detail about loop diuretics, how to dose them, how they work, et cetera. But I want to make one teaching point, and that is that as I talk a lot about left ventricular stiffening, what that does is it changes the end diastolic pressure-volume relationship. That is a reflection of the fibroelastic properties of the heart. And as the heart gets stiffer and stiffer, that relationship is shifted upwards and to the left. Well, what does that mean? What it means is that small changes in volume result in large changes in pressure because you're operating in this very, very steep part of the curve. It also means that if you can diurese someone, take a little bit of volume off of the left ventricle, those pressures can drop significantly. Changes of 20 millimeters of mercury in your left ventricular end diastolic pressure just by removing a little bit of LV volume. So diuretics are critically important in symptomatic patients. MRAs. There's been a lot written about MRAs, the mineralocorticoid receptor antagonists, because of this trial, the TopCat trial, published 9 years ago in the New England Journal. technically it was a negative trial. They randomized patients with HFpEF ejection fraction greater than or equal to 45% to either spironolactone or placebo, and they looked at a composite endpoint, cardiovascular death, aborted cardiac arrest, or heart failure hospitalization. And unfortunately, it wasn't met. It was a negative trial. However, in a subgroup analysis, it turned out that there was a signal that treatment with spironolactone could reduce heart failure hospitalization. Then there was a further analysis, and it turns out this is where it gets controversial. When you look at the experience in the Americas, and if you look at the experience in Eastern Europe, there seem to be two different trials. And when they pulled serum samples that were banked from patients who were enrolled in Eastern Europe, it turns out that those who were randomized to spironolactone, they couldn't find spironolactone in the serum samples, suggesting that they didn't get spironolactone. So it was a placebo-controlled trial. So if you restrict the analysis to only those persons who were treated in the Americas, there actually was a significant 17% relative risk reduction in that composite endpoint. So not the most convincing evidence, but I certainly think that if you have someone who's symptomatic on an SGLT2 inhibitor, it's appropriate to treat with an MRA. ARNIs. Well, I can't really give any talk about heart failure without talking about the ARNIs, the angiotensin receptor neprilysin inhibitors. Following the significant effect that we saw in heart failure reduced ejection fraction, Paragon HF tested the hypothesis that in those patients who have neurohormonal activation, that treatment with an ARNI will be beneficial. So this trial randomized 2,300 patients, well, actually about 5,000 patients to treatment with either sacubitril/valsartan or valsartan. And it was a negative trial. It missed its endpoint by, I think it was 7 heart failure hospitalizations. That would have been enough to swing the balance. Nonetheless, a signal that in this higher risk population who have elevated natriuretic peptides, that the treatment with sacubitril/valsartan may be beneficial. Now, there's one other signal that came from this. If we look at Paradigm HF and you look at the range of ejection fractions in those patients who were enrolled in the trial, you can see that between those who had an ejection fraction of 15% all the way up to 40%, there was a similar reduction in the clinical endpoints of more than 20%. However, that's not the case in those patients with heart failure and a preserved ejection fraction. In fact, there's an attenuation of benefit once you get to ejection fractions above 65%. It turns out you can push that a little bit further out for women than men, but nonetheless, you can see that there is an attenuation for sacubitril/valsartan when you get to higher ejection fractions. And as a result of that, I think it's appropriate to consider the use of an ARNI in patients who have an EF of less than 60%. And then lastly, what if you can't take an MRA and you can't take an ARNI? What about treatment with an ARB? And this now goes back to data that's almost 20 years old, looking at the CHARM PRESERVE trial and iPreserve trial, trials that showed that there was a potential signal that CHARM with treatment with candesartan or valsartan compared to placebo, that there was some benefit there in reducing heart failure hospitalization. So moving on from medical therapy, I think that it's exciting now to also think about device therapy. I like the fact that I get to talk about both medicine and devices, so it's a nice synergy at the end of the day. And I'll start by talking about remote pressure monitoring. So many of you are familiar with this. This is the CardioMEMS device. It is a wireless, batteryless device that's permanently implanted into a branch of the pulmonary artery and allows us to remotely track pulmonary arterial pressures. We can use that to guide decision-making around diuretic therapy. And this was tested in the CHAMPION trial. And we look at the subgroup of people that were enrolled in CHAMPION who had heart failure and preserved ejection fraction. There was a very strong signal that those patients were less likely to be hospitalized when the clinical team used the data from CardioMEMS to treat them with diuretic therapy. We also now have the advent of interatrial shunt devices for treating heart failure preserved ejection fraction. And the idea here is to take a high pressure circuit, which is the left atrium, open up an aperture into the right atrium so that you have access to a low pressure circuit. So it acts like a pop-off valve. It's particularly salient when patients are walking and you start to see increases in wedge pressure going from the teens up to close to 40 millimeters of mercury. If you can shunt just a little bit of blood across that interatrial septum, you can drop left atrial pressure and patients can walk further. Now, it turns out that this is not a very large aperture. It's only about 8 millimeters in diameter, and it doesn't create a very large shunt, only a QPQS of about 1.2 or 1.3, but it is enough to significantly reduce left atrial pressures. Unfortunately, in the reduced LAP2 trial, there was no improvement in the combination of death or non-fatal stroke. However, when one does a forest plot and look at the subgroups, there is a signal that emerges, and that is that 3 subpopulations did not do well. Men, those who were in the highest tertile of right atrial volume, so big right atria, and those who had the higher levels of pulmonary pressures. For everyone else, there was a signal, a very strong signal, that this was beneficial. We're still unpacking the results of this trial, but nonetheless, there is a lot of excitement about using these devices, not only in HFpEF, but also in HFrEF. We are soon to hear the results of the V-Wave trial, and Dr. Greg Stone will be presenting that shortly. There are other devices. You can shunt not only from the left atrium to the right atrium, but some devices like the Edwards device will shunt from the left atrium into the coronary sinus. And there are some that don't require a device at all. You can create a hole, you can create an interatrial communication and not need to leave a device back there, so you don't have to provide any antiplatelet therapy. Last topic to talk about is greater splanchnic nerve ablation. Now, at any point in time, about 25% of our blood volume resides in our splanchnic circulation, in the liver and in the spleen. And when that gets stressed, either from exercise or sympathetic activation, it gets shunted back into the central space, significantly increasing filling pressures. So if we could somehow modulate the control of the splanchnic vessels, cause it to vasodilate and to not vasoconstrict, we might be able to prevent that sudden increase in blood volume going to the central space. And this is the concept behind right greater splanchnic nerve ablation. A catheter is accessed, the azygous vein is accessed, and a catheter is advanced down, an ablation catheter is advanced down between T10 and T11, and current is applied to ablate the greater splanchnic nerve. And this has now been tested in an early feasibility and a first-in-human experience, data that were presented a couple years ago at the Heart Failure Society meetings showing early and sustained improvements in both quality of life as well as 6-minute walk distance. And the results of the Rebalance Heart Failure Rolling Cohort have also been published last year, showing that there is a reduction in the increase in pulmonary capillary wedge pressure with legs up, with low-level exercise, and with peak exercise, suggesting that by preventing the shunting of blood, we can actually allow a reduction in left atrial pressure with exercise. So in conclusion, HFpEF is a clinical syndrome with a heterogeneous number of causes. The expert consensus decision pathway has, I think, codified a very rational approach to medical therapy for patients with HFpEF. The data strongly support the use of SGLT2 inhibitors as foundational therapy in this population, as well as those with reduced ejection fraction. New therapies to target metabolic and inflammatory pathways are promising, as are devices to target volume and pressure. So with that, thanks very much for your attention.